Hello and welcome to this podcast on jaundice. I'm Rashmi Patel.
And I'm Ed Wallitt.
And in this podcast, we're going to go through basic discussion of jaundice. First of all, starting with the normal liver function and how that can be disrupted to cause jaundice, and how to approach jaundice in terms of the various different causes, breaking it down into prehepatic, hepatic, and post-hepatic, according to the clinical features and the investigations. And we'll illustrate this with a few clinical cases as well, just to try and explain the general approach towards jaundice.
And I think it's fair enough to say that jaundice is something you'll come across quite a lot, both in medicine firms and surgery
and
firms.
surgery as well.
It's quite often a teaching point. So it's quite useful just to get to grips with the basics. And actually, it's one of these things where if you understand the mechanism and you understand what's going on, you find it very easy.
Makes it a lot easier.
It very easy.
So let's start off then with normal liver function. And well, the liver, people say that the liver has over 101 or, thousands of different functions. But to break it down, they're mostly related to metabolism in some form, whether it would be normal protein, carbohydrate, or fat metabolism, or in terms of pharmacology, drug metabolism or hormone metabolism, and bilirubin metabolism, and this is really the key towards understanding jaundice. So I'm going to discuss now the basics of bilirubin metabolism and the liver's role in this process. So what is bilirubin? Well, it's a molecule which is derived from the breakdown products of hemoglobin from senescent red blood cells in the spleen. So what happens is that the red blood cells are broken down and the hemoglobin is separated into the globin protein molecule and the heme moiety. And then bilirubin is formed from the breakdown products of this heme moiety and is initially produced in what's called the unconjugated form, which is water insoluble. Now, this particular unconjugated form binds to albumin in the blood, and it's circulated around the bloodstream and eventually taken up by the liver, where it undergoes a process called conjugation. And this is mediated in the liver by an enzyme called glucuronidase. And what this does is it converts it from a water-insoluble form into a conjugated water-soluble form. And this can then be secreted into the bile ducts and into the small bowel, where bacteria in the gut convert this conjugated bilirubin into urobilinogen, which is excreted in the stool as stercobilin, or it can be reabsorbed into the bloodstream and metabolized again by the liver or excreted in the urine. So this next slide shows a diagram which just summarizes this process and makes it a bit easier to understand. And you can see that the initial stage of bilirubin formation as heme is broken down and taken up by the liver, where it's then conjugated, secreted into the gut, where it's converted into urobilinogen and stercobilin, and also the urobilinogen can be taken up again into the bloodstream and circulated back to the liver or excreted in the urine. And this is the so-called enterohepatic circulation.
And this, you can already start seeing from this diagram how you can see the distinctions between prehepatic, hepatic, and post-hepatic. So, and this is a really useful diagram it's not overly complicated, but it would just, if you keep this diagram in your head, you'll have more of an understanding of the processes.
So how does jaundice occur? Well, quite simply, jaundice occurs when the levels of bilirubin in the blood are abnormally raised. And as you've seen from that previous diagram, there's a few possible causes of that, which can be broken down either into increased production of bilirubin or some problem in the way that the bilirubin is metabolized or excreted. And so what happens if you have excess bilirubin in the blood is it gets deposited into the tissues. And this is really what gives rise to the symptoms and signs of jaundice, yellow sclera and yellow pigmentation of the skin.
But I think it's worth saying here that you really do have to have quite a lot excess before you get the clinical manifestations.
Right.
So usually they say it's 2 or 3 times the elevation of this normal serum bilirubin before you actually start getting any
that's correct.
sclera
see it clinically.
or skin
Yeah.
changes. So we've already touched upon this, but a basic approach to jaundice, which I think is a really, really useful one because it focuses on the sort of physiology and metabolism of bilirubin, is to divide up jaundice or hyperbilirubinemia into prehepatic, hepatic, and posthepatic. Now, when we are talking about prehepatic, it's all of those things that obviously occur before the liver. And the key process occurring there is the breakdown of red blood cells.
Yeah.
So the situation where you're going to get an increased breakdown of red blood cells, which is going to increase the amount of unconjugated bilirubin that you have, is going to be in a situation called hemolysis. Now, there are lots and lots of causes of hemolysis. You've got inherited causes such as phagocytosis, elliptocytosis, and acquired causes such as autoimmune hemolytic anemias, and then sort of weird and wonderful things like TTP and hemolytic remix syndromes and things like that. But any hemolytic state can cause jaundice. It's worth remembering, however, that this jaundice usually is quite mild, however. So it's actually described often, the jaundice with hemolysis is often described as a sort of lemon tinge, because often you get jaundice and anemia.
Pallor, and the combination.
So the combination of the two is described as a lemon tinge. So just watch out for that in questions, lemon tinge. It kind of points you towards hemolysis. The next thing is hepatic. Now, there are lots and lots of potential things that can go wrong with the liver and can cause derangement of the conjugation process and therefore cause jaundice. I like to use sort of surgical medical sieves in order to just go down a list and sort of fill things in. But the important things you need to remember are hepatitis, which is not just viral hepatitis, hepatitis A, B, C. You can also have hepatitis that's caused by bacteria, it's caused by fungi, protozoa, as well as autoimmune and, very importantly, drug-induced hepatitis. There are lots and lots of drugs out there that cause hepatitis. Cirrhosis, you can find jaundice in, particularly decompensated chronic liver disease or decompensated cirrhosis. Jaundice is a very important sign of decompensation in patients with cirrhosis. Malignancy, which obviously can be either primary or secondary. And then you can actually have almost what one might call physiological pathology, even though it's a sort of not really a statement, but you can have sort of physiological pathology, which can cause jaundice. This common condition called Gilbert syndrome, which is due to an inherited defect of that key enzyme, glucuronidase transferase, which does the conjugation process, but which doesn't really cause any particular problems.
We'll discuss this a bit later. So
and then finally, you've got the posthepatic causes. So that's anything happening after the liver. Now, the key thing we're looking at there is the biliary system. So the thing linking the liver to D2, the second part of the duodenum, where the bile drains into the gut. And any problem within that system can cause a blockage and can lead to jaundice. And actually, posthepatic jaundice is the one that usually causes the most sort of profound sort of acute presentation of jaundice, and certainly the clinical signs. Very, very deep yellow skin is often seen with this. Once again, any tube in surgery, think about luminal, mural, and extramural. So what could be in the lumen? Well, the biliary system, gallstones. 99% of pathology in the biliary system is basically gallstones. In terms of mural causes, tumours, you can rarely get tumours of the biliary system, particularly in association with things like primary sclerosing cholangitis and inflammatory conditions such as that. You can get strictures either because of old inflammation within the biliary system, or perhaps because of repeated procedures such as ERCP, which can cause damage. And then finally, you can get extramural compression. Now, this is a really, really important one. Tumours of the head of the pancreas in particular can very commonly present with jaundice. Very deep.
And that might be the only thing that the patient has initially.
Exactly. So that's just an overview. The key thing is, remember, prehepatic, hepatic, and posthepatic. Okay, so now we're just going to talk about 3 different cases as a way of illustrating a diagnostic process, a way of talking about the important tests that you want to do to investigate someone with jaundice, and then once again just to go over some important sort of causes. So this is a 25-year-old male who's recently returned from holiday in Southeast Asia 2 weeks ago. He's complaining of feeling unwell. He's got constitutional symptoms, nausea, loss of appetite, fevers, together with some abdominal pain. On examination, you notice yellow discoloration of the skin and sclera, so jaundice, and you feel a palpable liver edge. So should we just stop here and just talk what might be going on?
So I think this case, there's a few things you want to consider here. I mean, certainly someone who's returned from Southeast Asia, a malaria endemic area, who's come back presenting unwell with fevers, the first thing you want to rule out is malaria.
Absolutely, and that's a key thing here. Often, even though we're talking about the liver and we're talking about jaundice and things like that, I mean, malaria is a cause of hemolysis, and certain forms of malaria you can get quite profound hemolysis, black water fever variants, for example.
So this could explain...
This could explain everything, but the important thing is that so often in medicine, it's something that you must exclude.
Yeah, absolutely.
So anyone who's been away travelling like this and comes back unwell, whether they have jaundice or not, you need to think about something like that.
Yeah. I guess the other thing you want to think about is possibly other infectious causes, perhaps a viral hepatitis, someone who's come back unwell, abdominal pain, jaundiced. That might be another possibility.
Yeah. So how are we going to investigate this chap?
Right, so I suppose the first things you want to do are some blood tests, full blood count and renal function. And blood film as well, obviously we need to make sure that there's no malaria parasites. The full blood count as well might tell you if the patient's anemic or if the reticulocyte count is raised, and that might indicate some kind of hemolytic
process.
And then of course the liver function tests. So we can see here these liver function test results. They're clearly deranged, but the first thing to look at is the bilirubin, which is markedly raised here.
Very, very markedly raised.
And certainly would explain the yellow discoloration in the skin. And then the next thing you want to do when you're looking at liver function tests is to look and take a look at the AST and the alkaline phosphatase, because that gives you an indication of whether this is more a hepatitic process or a cholestatic process, something affecting the biliary tract. And in this case, the AST is markedly raised in comparison with the ALP, which would give us more hepatitic picture.
Exactly.
And then after that, you'd want to run a whole series of tests to try and work out the cause of this hepatitis. And these would include serology tests for the various hepatitis-causing viruses. And in this case, the patient was positive for hepatitis A IgM.
Yeah, and IgM, of course, is your sort of acute immunoglobulin that's produced. It's a pentamer. It's a thing that is produced very early in an infection. And if certainly it says IgM here, so that suggests early infection. But if it was say IgG, then you might wonder, well, did this person have hepatitis A?
Yeah, you wouldn't know if it was just IgG. Yeah,
and I think there's another point worth making with regard to the AST, which sort of gives you an idea about is this a hepatic process if it's elevated, and the ALP, which gives you an idea about is this a post-hepatic cause.
Yes.
Often, even with just a hepatic cause, you will see elevations in both things.
That's right. Yeah.
Don't get confused by that. The thing that you want to look at is which one is elevated more.
Yeah, in proportion.
In the other. So here you can see the AST is elevated much more in proportion to the ALP.
Yeah.
So that suggests a hepatic cause for the jaundice. It's also worth just quickly having a look at the albumin. And the reason the albumin is important is because the albumin is something the liver spends the majority of its time actually producing. It's one of the key synthetic function of the liver is to produce this thing. And in a patient with chronic liver disease, you'll often see a low albumin. So the fact that the albumin is relatively normal tells us that this is more of an acute sort of hepatitis rather than a sort of chronic picture. But more on that perhaps a bit later.
Okay, and now moving on to the second case, very common clinical presentation. 45-year-old female who comes in with a 3-day history of very severe upper abdominal pain, which she reports radiates to the right shoulder and is associated with nausea and vomiting. The other thing she tells you on direct questioning is that she's noticed her urine is quite dark, and this is quite a key point in the history, which we'll come on to in a moment. And on examination, you find that she's exquisitely tender in the right upper quadrant, and this tenderness becomes worse on inspiration.
So I think there are quite a lot of options in the differential diagnosis here. Yeah. Obviously, the fact that this is a 45-year-old female with right upper quadrant pain is pointing you towards a biliary-based
something to
pathology.
Do with,
But it's important to bear in mind that there are lots of these that are possible. So this could be biliary colic. The fact that it's 3 days makes us think perhaps it isn't, though. But biliary colic would come on, plateau, stay for usually a couple of hours, and then settle down.
Yeah.
This could be cholecystitis. This would certainly fit with a presentation of cholecystitis, so inflammation of the gallbladder, usually in association with stones, because she's systemically unwell and it's a long history. However, the dark urine is telling us something else about this patient.
There's something else going on.
Mainly, the dark urine is hinting at the presence of excess amounts of urobilinogen.
Yeah.
So it's pointing us towards the presence of a post-hepatic cause for this jaundice. So in this case, actually what we're looking at is an obstruction within the biliary system in association with right upper quadrant pain, nausea and vomiting, systemically unwell. This is a presentation of cholangitis.
Yes.
Okay? And this is a very important clinical picture to have in your mind, because it's a very serious condition which can result in septicemia and death if it's not treated rapidly. Right upper quadrant tenderness worse on inspiration. This is otherwise known as Murphy's sign, and essentially means that there's large amounts of inflammation around the gallbladder. In fact, Murphy's sign is a little bit different. It's when the tenderness is so exquisite that when the patient takes a breath in and you've got your hand in the right upper quadrant, the breath actually stops because the pain
and they
is
can't
so
actually
severe,
breathe in anymore.
and they can't take that breath. Okay. So do you want to go through the
Yes,
LFTs?
So let's have a look at these liver function tests. So as before, we start off by looking at the bilirubin, and it's slightly raised here, not so much as the previous patient with the hepatitis, but this might just be at the level where it could be clinically detectable, particularly if you were to look at it in the eyes or the mucous membranes, which tend to be the first.
They say just under the tongue.
That's right, that the first place where it might be detectable. Now, if we take a look at the AST and alkaline phosphatase, we can see that the AST is slightly raised, but looking at the alkaline phosphatase, that's markedly raised, and more so in proportion to the AST. So this points towards more of a post-hepatic or cholestatic cause.
Which is exactly what we were thinking with the dark urine.
Exactly. And now looking at the albumin, again, this albumin is normal, which suggests that this is more of an acute presentation.
Exactly, there hasn't been any chronic impairment of liver function. Mm-hmm.
So this patient had an ultrasound of their abdomen, and this confirmed clinical suspicion that the patient did have gallstones and a dilated common bile duct, which was highly suspicious of there being some kind of obstruction here. And the patient went on to have ERCP and a gallstone removed from the common bile duct, and then later on underwent cholecystectomy to remove the gallbladder.
Yeah, very, very good case here of a post-hepatic cause, one that you shouldn't forget, the presentation of acute cholangitis. Mm-hmm. So the final case we're going to be looking at is a 19-year-old male. He's recovering from an upper respiratory tract infection, and his girlfriend has noticed that his eyes have turned slightly yellow. He's otherwise feeling very well. He's got no other symptoms. On examination, you've confirmed that he is indeed clinically jaundiced, but you can't find any other positive findings such as hepatomegaly or any other worrying features. Yeah,
and this is quite an interesting case because you go on to do the liver function tests and you find that the patient has got a raised bilirubin, but actually the rest of the enzyme levels don't seem to be affected. And maybe you might be wondering about hemolysis at this stage because the AST and ALP are normal. However, in this case, the hemoglobin and the reticulocyte count is normal. You would expect the hemoglobin to go down and reticulocytes to go up.
So just for people who don't know, reticulocytes are immature red cells that are produced with a sort of acute drop in hemoglobin, as you see in hemolysis. Yeah. And they're actually, interestingly, they can also cause us like macrocytosis as well, because they're quite large reticulocytes, immature, large red cells.
You do see MCV going up a bit in hemolysis. Okay, and then going on, having a look at the urine, there was no bilirubin in the urine. Now, if you remember going back to the metabolism of bilirubin, you'll remember that there were two forms of bilirubin, the unconjugated form and the conjugated form. And the unconjugated form is water insoluble and so cannot be excreted in the urine, which suggests that if there is a high level of bilirubin in the blood but none in the urine, then it must be in the conjugated form. The unconjugated form, which is water insoluble. So this suggests a pre-hepatic cause. Yeah. He went on to have further hepatitis screen, and that was negative. And given that there was no evidence of hemolysis, this suggested possibly a disorder in the bilirubin metabolism. In other words, converting this unconjugated bilirubin into conjugated bilirubin.
This is a very, very common condition. It's usually familial and called Gilbert syndrome. If you see this picture of a well person with jaundice but normal liver function tests, this is usually the diagnosis. And to be quite honest, most people wouldn't go on and do hepatitis serology and urine and bilirubin and things like that. But we just wanted to illustrate.
So that you could understand the sort of process. Yeah. And it's caused by reduced activity in the glucuronide transferase enzyme, which is responsible for conjugating the bilirubin. This gives rise to Gilbert syndrome. Gilbert.
Yeah.
I wonder, which way you meant to pronounce it. I call it Gilbert.
Slightly more exotic.
Okay, so to summarise what we've discussed in this podcast about jaundice, we've gone through the basics of bilirubin metabolism. And that's the process by which the breakdown products of hemoglobin, the heme, form unconjugated bilirubin, which is water insoluble, and that this is taken up by the liver and converted to the water-soluble conjugated form and excreted in the biliary system. And it's important to just have a good grasp of this process, because that then leads you on to be able to understand a lot better the approach towards jaundice and being able to identify which part of this pathway is affected. And that gives rise to this classification of prehepatic causes and things which cause an increase in the unconjugated bilirubin, for example, hemolysis, or the variety of hepatic causes, anything affecting the liver function, and post-hepatic causes, which is anything affecting the biliary system, through which the conjugated bilirubin is excreted.
Yeah, absolutely.
So I hope you found this overview of jaundice useful. Thank you very much for listening.
And we'll see you soon.
Yeah, take care.